Hi, welcome to Detours Understanding Acquired Brain Injury. And today I want to talk to you about one of those acquired brain injuries that is not traumatic in nature. I want to talk to you about sepsis and how it can cause brain injury. With sepsis, what you're dealing with is the body's overreaction to an infection, where the body turns against itself in the process of fighting an infection. And we're going to talk today a little bit about how the body's immune system can cause permanent brain injury, and it can cause some rather serious long-term effects in these kind of cases. Now, there are a lot of factors that play into this, but sepsis, basically what it is a kind of a host reaction. So the people that are vulnerable to this are those who have usually issues with autoimmune disorders, or who have it in the family. There are certain genetic and epigenetic predispositions in many cases that the studies have shown. And they also may not have, and I'm not being critical of any hospital or anything here, but they may not have received adequate or sufficient care. They may also not have gotten to the hospital in time to begin treatment. And so these kind of pre-factors play into whether there will be neurological long-term effects. Also, sepsis, when you exhibit the symptoms, there are different paths it can follow, and we'll be looking at that as we go along here. All right, so usually in cases of sepsis, it is when the body's fighting a bacterial or fungal infection. And this causes the body to mount a reaction to it, to the infection, and activates all the body's defenses. Whereas with viral infections, it's not as common to get a sepsis type reaction. It does in some cases happen, but it depends on the virus. And it's not as much in those cases where you see brain injury like encephalitis or something along those lines. It's usually more the virus itself and a direct attack against the body of the virus. And so it's a viral caused, whereas in this case it is caused by the body itself, your own immune reaction. And so that's something to keep in mind here, as opposed to like encephalitis or a condition like that, or some kind of conditions like amoeba based or something else like that, like brain-eating amoeba or something, which is incredibly rare, by the way, like really, really rare. But in those cases, the organism itself attacks neural tissue directly. In cases of sepsis, you can have the bacteria causing damage, but the blood-brain barrier, which keeps organisms out, has to be degraded to allow for bacteria to get to the brain. And that does happen in cases of sepsis. We'll get to that in a moment. The blood-brain barrier does degrade, and that's important to some of the neurological injury. Let's move on here. So basically, the first things you'll see with sepsis, you may see some early symptoms that there is neurological involvement. The patient may initially, actually, even before sepsis has begun, where the body has begun to attack its own organs, you may even see the neurological symptoms first. You may see irritability, anxiety, some confusion, attention-related issues, stuff like that, before you even start to see the symptoms of sepsis, where you'll see an elevated temperature, which is typical in bacterial infections, thirst, tacky skin, elevated blood pressure and heart rate, at least initially. Later, those vital signs start to go down, where you will see, as the condition progresses, you will see reduction in urine volume. You will see lethargy. You will see generalized, what you'd call sick behavior. But these changes are much more rapid then, because they do reflect the body's response to infection. And as it progresses, then it can, in many cases does, eventually lead to death. But those who survive, we're going to be talking about two different conditions that are associated with neurological or brain injury. This is what the focus of the channel is. One of the first of the two conditions we're going to be talking about, which are associated with brain injury, is sepsis-associated encephalomyopathy, SAE. And I'll be using the term SAE to describe one of these two things. Now, SAE, sepsis-associated encephalomyopathy, occurs as a result of these processes, and this is how sepsis attacks the brain, how the body's immune system attacks the brain. There are two variants that you'll see with SAE. The first one is where you'll start to see these symptoms, and it's important to know that SAE is a diagnosis of exclusion. So the docs have to rule out other problems, such as like a fat embolus in the brain, or possibly an aneurysm, or rule out encephalitis, or rule out possibly a traumatic brain injury or something along those lines, progressive dementia, or those kind of things. So they have to rule out anything else it could be. And then what they're left with is SAE. And it may seem kind of strange that you're talking about these other things when it's obvious the person has an infection. You've drawn blood and they're like, oh, they're already showing elevated humoral markers, white blood cells are elevated. You're starting to say, yeah, it looks like they've got a pretty bad infection here. It would seem reasonable to call it SAE, but in medicine, you can't overlook these other factors because, yes, you can have multiple conditions at once. And this is something important for the general brain injury community to remember. Just because you have a brain injury doesn't mean you can't have diabetes, doesn't mean you can't have a stroke on top of it. In fact, many patients with traumatic brain injury also get sepsis. So it's important to keep in mind that it is critical, especially with a diagnosis based on ruling out other ones, a diagnosis of exclusion, this is called in medicine. You have to rule out other conditions. Then, finally, you'll come up with this as a diagnosis. And usually, this diagnosis is not applied till after you have fought sepsis, and they look at, the long-term effects. They're saying, yes, this person had SAE because they exhibited these symptoms. And so fighting sepsis is a matter of giving the patient the appropriate antibiotics, controlling blood sugar, oxygenating and hydrating, and making sure you're using broad-spectrum antibiotics initially, finding out what organism is involved, or antifungals, if it's a fungal-based, or and if on those rare cases it's viral, antivirals. There really aren't a lot of specific treatments for SAE, but so early on, you'll see one of these two kind of things. You'll either see agitation, the patient will be agitated, they'll be confused, they'll be disoriented, irritable. If you see that kind of pattern, it's more concerning because it means that, at least in relation to brain injury, because that pattern with the agitation, confusion, disorientation, the irritability, it usually means the prognosis is of long-term brain injury. It means that sepsis is focused on the brain. It means the attack is more brain-oriented. Whereas if the patient instead is exhibiting more stupor, lethargy, hypersomnolence, like a lot of sleeping is what I'm saying. If they're just kind of a lump mostly, and they're just like, with the sepsis symptoms, of course, the elevated fever, the tachy-skin, the rapid breathing, elevated blood glucose, stuff like that, and they're really sleepy, they're hard to arouse, that suggests that you're dealing more with it attacking, say, the kidneys, which are a frequent target in cases of sepsis, the liver, cardiovascular system, which are also often attacked in cases of sepsis by the body's immune system. Then you're dealing more with end organ and with things like MODS, multiple organ dysfunction syndrome. And in those cases, you're dealing more with an acute crisis for the rest of the body. And death rates are higher with this presentation of sepsis. And you usually are dealing with those kind of problems. And with treatment for that, dialysis is necessary, and monitoring blood sugar and using suppressors, fluids. But the other presentation is one where you're looking at the brain and long-term effects. You may have less damage to kidneys and heart and liver, and there's still a risk, but it's reduced because the brain is taking more of the hit there. So there's also something else that occurs sometimes in about 23% of the cases, and it's important to address this, and that is reversible occipital encephalopathy. Now, this happens along with SAE in many cases. Not exclusively, but it does happen. And it affects the back of the brain, the occipital lobe. And in cases of reversible occipital encephalopathy, RE, you get visual disturbances. So you may get things like hallucinations. You may see bugs or like snakes or stuff like that briefly because of disruption of the visual system, or illusions and distortions where something is there, but it's distorted in how you perceive it. About 23% of the cases have this kind of thing. But since their mind's not clearly operating, communication is difficult. A patient who's experiencing these symptoms and what they remember is difficult to say. They may be able to communicate it then, or they may remember it long term. It's very difficult. And the challenge is, how do you not have to sedate the patient if you can avoid it? Sometimes it's absolutely necessary, but other times you really do want to avoid, unless absolutely necessary, to put them down with like lorazepam or something like that, because that has its own long-term effects you want to avoid. And it can make things worse, not necessarily doing brain damage directly, but it can make the patient more agitated and they can put themselves at risk. The older neuroleptics, the antipsychotics, the older type, are often used if the patient is a danger to themselves or others. Haldol, Ativan, things like that. Again, you really want to avoid if you can. But some patients are aggressive and are a danger to themselves or others, and it is necessary to use these neuroleptics. Again, do you really want to? If you can avoid it, you do, but again, quite often it's necessary. So how does, what is the pathophysiology? There seems to be 3 different ways that SAE works. One of them is through the breakdown of the blood-brain barrier. The inflammatory factors that are released by the macrophages as they work on destroying the organism, the bacteria, or the fungi, or whatever it's attacking, they release specific factors, and these cause damage not only to the organisms, but they also destroy or weaken the blood-brain barrier. And this is problematic, obviously, because it risks allowing bacteria into the brain, which obviously would do their own destruction, but it also allows cytokines, which are inflammatory factors. You don't want those getting into the brain any more than necessary. And the brain produces its own inflammatory factors, so you certainly don't want extra inflammatory factors in the brain. But they can penetrate, and they will, if the blood-brain barrier is breached, and these get in there, yeah. And that's believed to be one of the causes, because it triggers an inflammatory reaction also in blood vessels, and it seems to impair microcirculation. So capillaries will swell up and burst or constrict throughout the brain, depending on which cytokines hit where. And it will then starve the various neurons of oxygen. Also, they trigger inflammation, and they set off the oligodendrocytes and set off astrocytes. And these guys' job, we discussed them before in the pathophysiology of brain injury. And their job is kind of like cleanup crew. But if they're triggered, they will attack neurons potentially. And if there's damage or injury there, and the cytokines may do damage directly to neurons, and they may facilitate destruction. And in turn, and also, we see neuronal apoptosis. Damaged neurons will self-destruct. We talked about this in traumatic brain injury also. And neurons without oxygen, due to circulation impairment, will destroy themselves. And so that becomes a problem also. A large number of neurons potentially would destroy themselves depending on how bad the sepsis is. Particularly neurons in the hippocampus, in the areas of the brain associated with memory, long-term and short-term facilitation, so the ability to store memories long-term, to switch from short-term to long-term storage are affected. Also, neurons in the frontal lobe, so executive skills potentially affected. Also, those neurons that produce acetylcholine seem to be affected, and these inflammatory factors target receptors of acetylcholine as well as norepinephrine. Both of them are excitatory neurotransmitters, and in the process cause the release of glutamate. That should be one you recognize from our other video on traumatic brain injury, which triggers a cascade of calcium release and destabilizes these neurons and causes them to destroy themselves. Also, we talked about how excess calciums and imbalance of electrolytes will cause neuronal self-destruction. And so cumulatively over time, you have a lot of cell death, and specifically mainly the temporal lobe and the frontal lobe, as well as more specific destruction in the thalamus, as well as in the hippocampus and the amygdala. So those areas that you often see with traumatic brain injury experiencing neuronal death also see destruction and death with sepsis. Very similar kind of mechanism to traumatic brain injury. It's just the initiating factors are different. There are experimental treatments to try and block and or modulate the effects of the cytokines here, which are responsible for triggering the inflammatory response in the first place in the brain. But that's still a lot of laboratory stuff, and hopefully we'll figure out what. We also find that this response impairs the functioning of the mitochondria. Excess waste produced, the mitochondria are not capable of processing it, which also kills neurons. So long-term, depending on how severe the sepsis is, it can be very devastating and cause a lot of... So also, it's then important for us to figure out whether a patient has sepsis. And one of the ways that helps in this diagnosis of exclusion is the use of a CT scanner to rule out any kind of bleeding, any things like that. An EEG, interestingly enough, can help, because one of the signs, electrically speaking, is epileptic activity that is non-convulsive. So it looks like a seizure, but it isn't, but you don't get the convulsions. So when you look at the brain, you will see the triphasic waves, you'll see high voltage spikes and slowing in certain areas, temporal, frontal, but you won't see bodily convulsions. MRI, not necessarily as useful immediately, but over time, over 3-6 months after recovery, a year, you will see in more severe cases, you will see literal shrinking of the brain due to a large amount of tissue loss in the more severe cases. Obviously, the earlier you see this and the more tissue loss there is, more brain tissue loss there is, the more serious the cognitive side effects. So what are some of the long-term effects caused by SAE? Cognitively speaking, verbal fluency problems with word finding, again, a lot like a person with traumatic brain injury. Functional memory problems, like day-to-day memory issues, remembering like certain skills and things like that. Verbal memory, remembering like for school assignments or for like work assignments, retaining what was explained to you, like stuff that was visual spatial problems are often an issue. So these are the long-term kind of stuff that lasts a year or more, even permanently in some cases. In the most severe cases, you can see a significant drop in IQ score. These are about 1/3 of the severe cases of sepsis. Also, like I said, up to 10 points of IQ, which is a significant drop, and overall adaptive functioning. Also, this is seen with patients that are a little older, although younger patients can have this happen to them too. Usually the changes, if they're visible within 3 to 6 months, it's likely that a patient with this had suffered very severe SAE, and SAE, it's encephalomalacia, basically. Is what you have. Emotional symptoms include things like depression, anxiety, increased irritability, sensitivity to light, sound, things like this reflect on a patient who had SAE. There is significantly a threefold increased risk for non-Alzheimer's dementia of the different sorts. So they're at risk for getting sepsis again. So that is also something that patients with SAE have. There's also, and I want to talk about this, something which is similar and probably has similar cause, and it's more about, again, a diagnosis of exclusion, which is Post Sepsis Syndrome. Again, this is one of exclusion. It has features, cognitive and emotional features of SAE. We see this associated with damage to temporal and frontal lobe. It's noted in about half the patients who recover and have perhaps mild to moderate cases. The more severe cases tend to have the symptoms directly associated with SAE. But post-sepsis syndrome, PSS, they often had trouble with their pre-sepsis health. They had a lot of autoimmune problems, again, a lot of general unwellness, an environment that was unhealthy for them. They had a lot of health habits that weren't the greatest, so they're more vulnerable there. Their hospital care may not have been as strong. They tend to have long-term cognitive disabilities. They have generally short-term memory, declarative memory is affected, executive problems, planning, organizing, thinking ahead, seeing the big picture, that kind of thing. Working memory, processing speed is affected. It takes them longer to come up with answers and solutions. They often, it's like, you need to keep in mind that they're more likely to have these problems if the length of time between when they started showing sepsis symptoms and when they got to the hospital, when they started antibiotic treatment, fluid rehydration, those kind of things, the more severe the symptoms. Some of the physical symptoms of post-sepsis syndrome include things like generalized pain, loss of taste and smell, fatigue, dry skin, nails, loss of hair or hair falling out, lack of appetite, insomnia, swollen joints and limbs, and generalized weakness, malaise, more frequent infections. Now, this happens more often in the beginning. They do then start to statistically level out as far as the more frequent infections, but those are just some of the physical symptoms. Kidney problems, oftentimes, problems with balancing their fluids. There are increased risks for cardiac problems, increased risk for cholesterolemia, hypercholesterolemia, and so cardiac issues that come with that as well, cardiac scarring, and respiratory issues as well. So those are some of the physical issues. Psychological, of course, PTSD. A lot of patients really fear getting it again for very good reason. They are at increased risk. Anxiety, depression, flashbacks, nightmares, some hallucinations occasionally. They have obviously short-term memory loss, mood swings, lability. The cognitive deficits that we'd mentioned earlier are common. Short-term memory loss, lack of motivation. So and depending on how much brain injury is involved. So these are what you see for Post Sepsis Syndrome. So 2 sources of neurological injury for patients who have sepsis. Unfortunately, treatment for sepsis-associated encephalomyopathy and post-sepsis syndrome, really not a lot. Rehabilitation is the big one. Make sure it's what you got. It's like confirm your diagnosis, and it's rehab. Rehab is what you do. Cognitive rehabilitation and counseling, therapy, medications for it. Make sure you jump on any infection that you exhibit. That's what treatment is currently. Try to treat the sepsis as quickly and effectively as you can, because you reduce the damage the more aggressive you are in taking care of the sepsis. You want to avoid steroids in treatment if possible, because steroids, actually, research shows they tend to exacerbate. Glucose, you want to try and control glucose levels. Too high can cause problems. Too low, obviously, can cause problems. So it's a matter of striking a good balance. Maintaining blood pressure. Too low of a blood pressure can cause permanent problems also. And so there are some experimental treatments out there. A drug class called SERTs do have the potential to mitigate some of the cognitive damage, because these are some of the pro-inflammatory factors that directly attack neurons, as well as affect the microcirculatory attacks by the immune system that cause the neuroinflammation. And so by inhibiting these cytokines, you can reduce the inflammation in the circulation and prevent the hypoxia, but it's still brand new, like lab kind of new. And so when that gets out there, who knows? There have been other attempts to find other blockers, and these have failed. So who knows where this will lead? Will this be successful or not? Don't know. There were attempts to use vitamin C. The effectiveness of vitamin C in the treatment of sepsis, unknown. Right now, it seems like it may work, maybe not. This is one of those where the stats are kind of equivalent, or equivocal, with apologies, equivocal. So, guess we'll find out. In the next episode, I would like to introduce 2 friends of mine who have suffered attacks of sepsis and who do have cognitive impact, who have suffered SAE, who have post-sepsis syndrome. And they will be talking more about their experiences with as time goes on. They will be doing a little bit of co-hosting also. So I just wanted to discuss the clinical side, the pathophysiology, the symptoms, the neurological implications of all of this, and some of the pathophys and some of the symptoms here and things like that, and just address this, because people with traumatic brain injury are also at an increased risk for this. This is something to be aware of, and to be aggressive with the treatment of infections when they start, especially if you have autoimmune issues. And a lot of people with traumatic brain injury also do have autoimmune problems, and so it is important to know and not to allow it to progress, if at all possible, to becoming sepsis, because it can lead to far greater neurological impairment. And so it's important to jump on top of infections, talk with your physician, get tested, so that it doesn't become something far worse. Thank you. I do want to say to those, please, if you like this channel, please share. Please encourage to like and subscribe. This is the way this information gets shared with other people. It's important to convey this kind of stuff. So I just, again, want to urge you to share it, to encourage people to click like and subscribe. Hope you found this information helpful, educational, and hope you also find the next program with our co-hosts helpful and are able to use it to the maximum potential. Thanks, and have a good day.